Y además creo que resaltan algo muy relevante y creo que ahora con fibrosis quística vamos a volver a insistir, y es que nos sirve mucho hacer un diagnóstico si no podemos hacer no solamente un tratamiento, no solamente ofrecerles una fórmula, sino que, como mostraba Verónica, preocuparnos de aspectos tan que podrían parecer, cuando uno diseña el programa inicialmente, tan poco relevantes como podría ser la densidad mineral ósea, un montón de otras cosas que son fundamentales cuando vemos un programa de pesquisa neonatal. Así que creo que Verónica nos mostró de manera brillante cómo entonces estas acciones tienen que tener eh, diferentes aristas y tenemos que abordar integralmente a estos pacientes. Bueno, cambiemos de tema, pero de nuevo vamos a insistir entonces en el mismo punto, pero ahora con otra condición. Y nos vamos a cambiar a la fibrosis quística. Y para eso tenemos ya conectado al doctor Richard Parat. El doctor Richard Parat es neonatólogo y profesor de pediatría en el Departamento de Medicina Neonatal de la Facultad de Medicina de Harvard, en el Brigham and Women's, que es uno de los hospitales asociados a la Universidad de Harvard. Dirige el programa de medicina genómica neonatal del Brigham and Women's y su investigación se centra en la secuenciación genómica para la detección y el diagnóstico de trastornos en recién nacidos, así como en ensayos clínicos para mejorar el tratamiento de los trastornos pulmonares neonatales. Él obtuvo su título de médico en la Universidad de California, en San Diego, y completó su residencia y beca en el Hospital de Niños de Boston. Realizó una doble formación en medicina perinatal, neonatal y neumología pediátrica en Boston Children's. Es director del programa de genómica neonatal y además el doctor Parat ha tenido un importante rol en la incorporación de la fibrosis quística en los diferentes programas estatales a nivel de Estados Unidos, particularmente obviamente en Massachusetts, el estado donde él vive. Y forma parte, de hecho, hoy día del comité de pesquisa neonatal que evalúa nuevas patologías a ser incorporadas en el estado de Massachusetts. Así que la verdad es que un tremendo honor poder invitar al doctor Parat, que no lo veo en la cámara, pero imagino que está ya conectado porque estábamos recién chateando. Así que, doctor Parat, welcome. You can start your talk.
Thank you, Francisco. Can you hear me?
Yes, perfect.
Okay, and I still cannot turn the host won't let me turn my camera on, so you'll have to look at my silly picture unless they release my camera. But I'd like to thank, there we go. Thank you. I'd like to thank the Harriet Joyce Foundation for inviting me to speak about cystic fibrosis and new advances in the field and why newborn screening is potentially so important. And I will be talking about a new class of drugs that have become available so that now babies can be detected early, started on therapy early, and their outcomes have been dramatically improved. My disclosures, I do receive some funding from Harriet Joyce Foundation regarding research on newborn screening in Ecuador. So first, let me talk about this rare disorder a bit. Cystic fibrosis is a multi-system disorder caused by alterations in a protein called the cystic fibrosis transmembrane regulator, which is produced by the CFTR gene. Cystic fibrosis is a little hard to understand why so many systems are not working properly. The way I like to think about it to understand things is to think about pipes and clogged pipes. The three classic organs that, or four that people think about when they think about classic CF are the lungs. The lungs have many pipes to let air in and out. The pancreas, which has a large duct in the middle, which allows digestive enzymes to enter the intestines. The male reproductive organs, the vas deferens, which is a tube that allows sperm out of the testes, and then the skin, where there are sweat glands, which are tiny pipes that produce sweat. If those pipes are clogged, and they are in cystic fibrosis, then the organs start to fail or not function normally. And the reason why these pipes get plugged are that there is normally in these pipes or tubes in these organs, there is normally a layer of epithelial cells that are coated with a thin layer of water, and the cystic fibrosis protein allows water to be on the surface of these cells. If that protein isn't working, then the water becomes, and secretions there become very thick, and the tubes get plugged. The inheritance of cystic fibrosis is classic autosomal recessive inheritance. A CF carrier has one copy of a normal CF gene and one abnormal copy in all of their cells. So, and each egg and each sperm has one CFTR copy. So in CF carriers, for women, half of their eggs and half of the sperm have an abnormal CFTR gene. Carriers themselves have no symptoms, but CF is caused when a child, a newborn, inherits one abnormal CFTR gene copy from each parent, so there's a 25% risk of two carriers having an affected child. This CF protein, here's a cartoon depicting it, and what it does, it lives in the surface, the membrane of epithelial cells that line those pipes or tubes that I described, and it acts, the protein is a channel which allows chloride and water molecules in and out of the cell. If the channel is closed and it can't let water out of the cell, then the mucus layer that coats the surface of the membrane and the inside of the tube becomes thick and dehydrated and dysfunctional. And there we go. This cartoon, if I can get it to work, will doesn't want to work. So I'll just describe that. Oh, there we go. The cell membrane, there we go. These are epithelial cells with little cilia on top of them. They sweep back and forth and they move that liquid mucous membrane along. This chloride channel lets water from the inside of the cell to the outside of the cell to hydrate that layer. These little yellow molecules are chloride molecules that follow with the water. And if that channel is not working, then water can't leave the cell. Okay, this gene, the CFTR gene, lives on chromosome 7. So the normal gene is has 27 exons. It makes an RNA that's about 250,000 base pairs long, and it makes a protein. The CFTR protein is about 1,500 amino acids. It's a sort of medium to large size protein made up of a number of domains. The blue and green ones here live in the membrane. They anchor the protein in the membrane, and then there are some portions that live inside the cell. People who have the most common mutation or variant found in the CFTR gene, which is called F508del, have a deletion of 3 base pairs in the 10th exon of the gene, and this leads to 1 amino acid, phenylalanine, missing from one of the nucleotide binding domains. As a result of this, the protein that's made is not able to travel from the inside of the cell to the cell surface, and it becomes destroyed by mechanisms in the cell that detect abnormal proteins. Delta F508 is just one of over 2,000 mutations that have been reported in the CFTR gene. Each mutation is located in a different portion of the protein and therefore affects the protein differently and may cause a different severity of disease. And also, those mutations, the frequency of them varies in different populations. So, for instance, in the United States, about 70% of CF mutations are this delta F508 mutation. But as far as we know in Ecuador, it's only about 30%, so less than half as frequent. So other different variants make up the rest of the CF mutations. This will become important as you hear the rest of the story because new drugs that have been developed are mutation specific. Each drug does not work in every patient depending on what their mutations are. We don't know what all the mutations are necessarily at the moment in Ecuador, and so it's not clear how many patients would respond to the medications or how the medications might be selected. So it's an interesting concept in cystic fibrosis that you need to know what the mutation is, the genotype, in order to select the new type of drug to try to treat the disorder. So with all these different mutations, and these are just some examples, they have been categorized in different classes. There's 6 classes, and this is after many decades of research of studying the mutations that they've been able to been placed in these categories depending on what kind of functional problem is caused in the protein. That may range from not making any protein at all to making a protein that can't make it out to the cell surface, to a protein that makes it to the cell surface, but the channel isn't functioning normally. And so different drugs actually may help those different problems. In addition to these drugs that we'll be talking about that are called CFTR modulators, there are other areas of research in CF looking at RNA therapy and gene therapy. And I won't be talking about those today. I'm going to focus on CFTR modulators because they've been so effective, at least in the United States. So these modulators fall into at least 2 categories. One category, the correctors, are small molecules that bind to the abnormal CF protein and help it make it up to the cell surface. It's still not a normal protein, but at least it's giving a try, and it's out there at the cell surface trying to work. The potentiator drugs work on proteins that have made it to the cell surface and help that channel open up to let things back and forth. So a drug called ivacaftor, which was the first modulator, was a potentiator, and it was effective for people who had this specific mutation in the CF gene, G551D. It allowed them to have their chloride channels work more effectively. It was then sort of realized that maybe if you put 2 different types of modulators together, or 3 or 4, that maybe you could help fix some of the variants that didn't respond to one alone. And this is just another cartoon showing that potentiators take protein that's in the cell surface, make them work better. Correctors help get mutant protein that hasn't made it to the surface out to the surface where the potentiator may be able to help it. And again, here's the airway here with an epithelial membrane and the abnormal protein that could potentially be aided by a potentiator like ivacaftor. Now, the CF diagnosis is made on the patient by measuring the amount of chloride in their sweat. And a sweat chloride above 60 is considered true CF. There's sort of 2 types of CF in that true CF category. Those patients who have very minimal pancreatic disease and fewer digestive problems, and those who have serious pancreatic disease. And again, the mutations, the variants tend to separate themselves into categories. Delta F508 is one of the most severe variants and is associated with both lung and pancreatic disease. There are milder forms of CF where the patients also have lower sweat chlorides, and carriers who generally don't have symptoms but may be at risk for some problems tend to have normal sweat chlorides. I'm going to try again and see if the video can work here. But this video shows how these drugs can potentially help the protein work normally. Let's see if this is going to go.
When making a normal CFTR protein, messenger RNA, the long strand at the bottom, holds the genetic code and gives instructions for how to make the protein. The round structure is called a ribosome, which reads the instructions from the RNA and assembles the CFTR protein. The protein is made up of building blocks called amino acids, and these form different structures called domains that fold together like a puzzle. Each of these domains has a different name, such as TMD1 and NBD2. All the domains fit together to form a functional CFTR protein, and the area where they fit together snugly is right where an amino acid building block called F508 is located. When the F508 building block is present, the protein folds properly and is moved to the cell surface, where it then functions as a chloride channel that balances salt and water at the surface of the cell. However, in people who have the F508del mutation in CF, the F508del amino acid building block is missing. The puzzle pieces no longer fit together properly, and CFTR is unable to make it to the cell surface to function as a chloride channel. New drugs are being developed to help fix the CFTR protein in people who have the F508del mutation. These drugs are known as correctors. They bind to the CFTR protein and help the puzzle pieces fit together properly. The first corrector that has been developed and approved by the FDA is lumacaftor. Researchers have found that adding a second corrector drug can even further stabilize CFTR. Once stabilized, the CFTR protein is ready to be moved or trafficked up to the cell surface and function as a chloride channel. Now, the corrected CFTR protein is being formed, then moved through the cell and up to the cell surface, where it can now function as a chloride channel. Once the corrector-treated CFTR reaches the cell surface, another drug known as a potentiator can be used to bind to the protein and further open up the chloride channel. The first FDA-approved potentiator drug was ivacaftor. Through corrector and potentiator drugs, the CFTR channel is now able to better function and restore a healthy balance of liquid on the airway surface.
Okay, I think I'm going to abandon. I hope you got the idea from the video, how those drugs can help make that protein work better. The next information about those drugs is just sort of a timeline of what has happened since the discovery of the gene that causes CF in 1998. And the drugs have been developed since 2012. There have been now 5 of them. The most recent one is Aliftrek, which was approved by the FDA in 2004. The initial drug, Kalydeco or ivacaftor, was a single drug, a potentiator, and then they figured out combining 2 or 3 drugs would work better and for different mutations, or it can be the next one, worked for patients who had 2 delta 508s, Symdeko for those who had 1 delta 508 and another variant, and then Trikafta for patients who had at least 1 delta F508. And Vertex is the company that's made most of these drugs. Interestingly, the drug that's been around the longest now has the longest safety profile, and the way these drugs can be used only down to certain ages. The newest drugs have the shortest experience, so they are not able to be used in the youngest patients. The longer we have experience with them, the lower that age limit is going to go down. So ivacaftor is the oldest drug, and it can be used in newborns, but the safety of the newest drugs has not yet been tested in younger children. The FDA always starts with testing adults and then older children, and then they move down to newborns. So the newborns don't get to take advantage necessarily of the newest drugs until there's more experience with safety. I'd like to move away from modulators for the moment and talk about another intervention which has improved outcomes in CF patients, and that's newborn screening. And just sort of this common sense approach here is that earlier diagnosis and earlier initiation of therapies can lead to improved outcome. So for CF, since around 1980 in some parts of the country, the Guthrie card that is used for PKU testing, as you heard about in the last talk, could now be used to collect samples to do a test to try to identify babies who had CF. And we are now learning, as modulators can be used in younger children, that earlier initiation of modulators leads to less damage to the organs affected in CF and better outcomes. Sorry, there's this big square in my screen. I don't know what that is or whether you can see it. I'll do my best to get rid of it. So in the past, in the upper left corner, children with CF would often present at around 4 years of age, 5 years of age, with severe malnutrition. This was because their pancreas was not working and they could not absorb fat. They had fat malabsorption, and their nutrition was very poor. We didn't have a test for CF until the 1950s, the pilocarpine iontophoresis test. But being able to make a diagnosis and make it earlier allowed therapies to develop, and pancreatic enzyme replacement is really one of the basic therapies, even far earlier than the modulators. You can see here on the upper right corner that the median predicted survival age has been slowly increasing with CF as we are able to make earlier diagnoses and as we have more therapies available, so that patients who were born in 1990 had a median age of survival of around 30, but patients born in 2021 now have a median age of survival almost double that. And that is because of improvements in CF care. Okay, so this timeline just shows you that therapies have been developing since in 1938 this disorder was first named cystic fibrosis. And those began with pancreatic enzymes, with antibiotics to treat lung disease, and then some respiratory medications. Newborn screening entered the scene in the late 80s or 90s. That has contributed to improve survival. So that was on the scene before these modulator drugs appeared. And then with the modulators, survival has continued to improve. When I first trained, the median age of survival was about 5 to 10 years of age. And now it's over 60 years of age. So just in my lifetime, there's been a dramatic change for these patients. But it does require early diagnosis and very specialized therapy and some very expensive therapies to improve that care. Okay. This timeline again shows things were fairly static until the 1980s when newborn screening came on the scene, and then with modulators, life expectancy has just started to skyrocket. I really do not know whether you can see this box on my screen, but I'm going to keep going. These are a registry kept by the North American CF Foundation. I'm going to talk about registries again at the end here, where they collect data on about 30,000 patients in the United States each year. And this allows for very important quality improvement interventions and creation of guidelines to continually try to do better in improving survival. You can see just over a 5-year period in looking at the pulmonary function measure, FEV1, where 100%, around 100% is a goal, is that the appearance of these modulator drugs are associated in a very large cohort with improved pulmonary function over time. And this is the most recent survival curve available from the CF Foundation, which shows that for babies born in the 2020 to 2024 epoch, the median age of survival predicted is 65 years of age. So half of CF patients will live beyond age 65, but half will not, and those patients still need very aggressive therapies. This superimposed on that survival curve is the appearance of the modulators, most recently the triple ETI drugs, which are making a very significant impact on survival in these patients. Now, when Kalydeco or ivacaftor was first brought on the market in 2012, it could only be used in 5% of the CF patients who had that one variant, G551D. It was not useful for patients who had the most common variant. So people kept working on trying to find other small molecules that would work for these other variants. And when the multiple drugs started coming on the market, they increasingly were able to improve the care of patients with different variants, such that currently in the 2020s, over 90% of CF patients should be responding to one of those 5 drugs that are available. Now that's partially true in the United States because Delta F508 is so prevalent. Again, if it were not to be so prevalent, then probably a smaller fraction of CF people with CF might respond to these medications. And this is just a table of showing that you must know the variants to select the drug. Some drugs do not work for patients with some variants, and so having genomic information is very important in directing the care of CF patients. This is again a summary of the modulator drugs and what ages they can be used at, and a little example of what kind of impact. This is this little graph on the right shows using Trikafta, which is the most currently used triple drug for CF in patients right now, that in the studies that got the FDA to approve it, their pulmonary function on the green line improved dramatically over the baseline while on the drug, and that's sustained on the drug. And they also find that the sweat chloride level can go down into a normal range. They have fewer pulmonary infections requiring hospitalizations, fewer respiratory symptoms, and better weight gain. So the drug seems to improve all those piped organs that where the tubes are being cleared out and the organs can function better. And this just shows the uptake of Trikafta over the past 5 years, that a very large, a significant number of patients are on this drug in the United States. However, the little dark level at the top, the 6%, are patients who have variants that would not respond to the drug. And then there are the younger children who can't take Trikafta yet because the FDA hasn't approved it. And then there are people in the United States who are eligible but haven't started on the drug, or whose insurance company will not pay for it, so the patients can't afford to do that. So overall, these modulator drugs seem very effective in improving ion transport through the CFTR protein. Those patients then have improvement in their respiratory status, in their nutritional status, in their quality of life, and they're less of a burden on the healthcare system because they're hospitalized less and they are more productive people. They're not limited by their severe symptoms. And these symptoms or the benefits of the drug are sustained as long as the patient remains on the medication. These maps just are to give you a sense of where the CF burden is around the world. The gray areas are ones where there really are no data, and this brings up the registry issue again, which is where it's really important to collect data within countries to have some sense of how many patients there are, where they are, what their variants are, to try to design support systems to try to get them these medications. Interestingly, India has almost no newborn screening at all in the country of India, and yet it's estimated that they have more CF patients than the United States. They're going undiagnosed, and the medications are also not necessarily available in that country. This little bar graph on the bottom shows an estimate of how many CF patients there are in the world, about 160,000. Only about 100,000 of them have been diagnosed with CF, and only about 20% of those are actually receiving these drugs. So there's a big gap between having the disease, knowing where the patients are who have the disease, and getting the therapy to those patients. If one were to try to make some interventions, I would say advocacy is incredibly important. That's been true in the United States for the Cystic Fibrosis Foundation, which was started by parents of young children with CF who banded together and raised money and made a lot of noise to continue to raise money and focus the research, which has allowed these drugs to be developed and allowed for policies to provide care, the complex care that these patients have. Unfortunately, one of the problems is the cost of these drugs. And so for some lower middle income countries, these drugs may be unaffordable at the prices that they're sold for in the United States. However, I know that Vertex does work with countries to sort of find some cost that might be tolerable to the country, and global reach is something that they've been working on the last few years to try to get more drug to more patients around the world. So this last slide is about cystic fibrosis in Ecuador. There are some grassroots organizations in Ecuador, a sort of a CF Foundation equivalent. My understanding is there are groups in Cuenca, in Quito, in Guayaquil, who are parents trying to work for better care for their children. We don't know how many people in Ecuador have cystic fibrosis. It's been estimated that the incidence is about 1 in 11,000 births. It's not quite as common as in the United States, but we don't know 100% what the incidence is. That would work out to be 20 to 30 new cases each year, and there may be 500 to 1,000 patients in the country, many of whom may under or undiagnosed. We know that FDAL508 is not the most common variant in Ecuador, but we don't necessarily know what are the most common variants. There are a couple of papers in the literature where people have tried to do this, but we really need more data to know what they are and what drugs would work with those particular variants. We know that Vertex has not been able to license these medications yet in Ecuador. but they have a strong interest in doing that. So that is something that the Ministry of Health can potentially do to help get the drugs into the country. We also need to find ways to have sweat labs and CF multidisciplinary CF centers set up throughout the country, at least in the major cities, so that diagnoses can be made. And also there needs to be a way to genotype these patients, to sequence their CFTR gene. And efforts are also being made through the Harriet Joyce Foundation to develop in-country sequencing capabilities so that Ecuadorian patients, not only with CF, but with other rare disorders, can take advantage of the information provided by sequencing. So what do we need to make progress here in Ecuador? I think the parent groups that are out there, and I've just started to communicate with some of them, their being advocates is incredibly important, and they need to unite and use their numbers to try to push through some of the policy issues. Newborn screening is one of those policy issues. I know adding CF as perhaps the next disorder added to the 4 that are screened for in Ecuador has been suggested, and I think the louder the voice of the parent advocates, maybe the more likely that is to happen, but that is another thing that Harriet Joyce Foundation is trying to support. We need these multidisciplinary care centers, because it's a complex disease, and one pediatrician does not have enough experience or time to keep up on what the latest best care protocol is. And that's where a central cystic fibrosis foundation is very helpful in helping to spearhead the development of those guidelines and the funds to support bringing together all the specialists needed to take care of one patient in a single clinic where the patient can easily go, instead of having to go to a GI person and a pulmonary person and a respiratory therapist all in different places. They bring it all together in one clinic and make the care easier for the patients. Developing a registry, I believe, is incredibly important. So find the patients, know everything you can know about them, collect the data, and then you have a baseline. And you can use the quality measures that have been used in other countries to try to start making a dent in this chronic disease. I think with that, I'm at the end of my slides, even though they're sticking and not moving forward. And I'm happy to answer any questions that people may have.
The other 2 speakers for the roundtable. So we'll ask you to stay